Welcome to this explainer. We're diving straight into the ultimate medical detective work today, deciphering the endocrine system. If you've ever wondered exactly how clinicians tackle this incredibly complex web of hormones that literally governs almost everything we do, well, you are in the right place.
Think about this for a second. How exactly does an invisible impulse, like just a fleeting thought or a sudden moment of stress in your brain, somehow trigger a cascade of massive, tangible physical changes across your entire body? It's kind of mind-blowing, right? To answer that, we really have to look at the body's internal communication infrastructure.
All right, so here's our roadmap for today. We're going to cover 1. The chemical messaging network, 2. Diverse hormone sources, 3. When communication breaks down, 4. The root causes, 5. Deciphering the symptoms, and finally, 6. Playing medical detective.
Jumping into Section 1, the chemical messaging network. To really get this, we need to understand the baseline, which is this beautifully integrated network of regulatory signals designed to keep your body perfectly balanced. At the absolute core of all this, we've got hormones. These are those specialized chemical products pumped out by endocrine organs, and their whole entire job is intercellular communication. Basically, they're the chemical messengers that link your endocrine, your nervous, and your immune systems together into one giant, highly integrated regulatory network.
Now this is where it gets cool, because these messages are routed differently depending on what the body needs in that exact second. It's not just a blind broadcast. Sometimes a cell is literally just talking to itself. That's an autocrine action. We see this with insulin or leptin acting right at their cells of origin. Other times, a cell is just kind of whispering to its immediate neighbors. That's a paracrine action, like gastrin in the stomach. And then, of course, you have your true endocrine action, where messengers like ADH, dopamine, or oxytocin are broadcast out to completely different sites across the body.
Moving on to Section 2, diverse hormone sources. We know how the messages travel, so let's look at the hardware actually sending these signals.
When we think about the endocrine system, we usually picture the traditional setup. You know the ones. The dedicated factories like the pituitary gland in the brain, the thyroid gland in the neck, the adrenal glands sitting right on top of the kidneys, plus the pancreas and the gonads. These are the classic heavy-duty engines we all learn about.
But here's a real game changer. We now know that the endocrine system extends way beyond those traditional glands. There are non-traditional sources constantly pumping out vital hormones too, like your GI tract. It's busy producing cholecystokinin and the hunger hormone, ghrelin. Your adipose tissue, your body fat, is not just stored energy, it is an active endocrine organ secreting things like leptin and adiponectin. Even your central nervous system gets in on the action, producing peptide hormones like GnRH and CRH. So today, we classify hormones based on their functional roles, not just their geographic origin in the body.
Section 3, when communication breaks down. So, what actually happens to a patient when this incredibly balanced server just goes offline?
Basically, the systemic chaos falls into two main functional buckets. On one side, you have hormone excess, way too much signal. This happens because a primary gland is just overproducing on its own, or it's being driven secondarily by an excess trophic substance, like a bossy signal from another gland forcing it to work harder. On the flip side, you have hormone deficiency, nowhere near enough signal. This is either a primary failure of the gland itself or a secondary failure because it's missing the trophic hormone it needs to even get started.
Section 4, the root causes. Let's actually peel back a layer here and look at how these functional problems manifest biologically.
If we're dealing with hormone excess, the culprits are all over the map. You might be looking at a neoplastic growth, like a benign pituitary or adrenal adenoma producing excess hormones because its negative feedback loop is broken, which is exactly what happens in Cushing's disease. Then you have autoimmune disorders. In Graves' disease, for example, the body makes antibodies that maliciously mimic TSH, forcing receptors to overproduce thyroid hormone. You could also see genetic mutations like MEN1 and MEN2 syndromes causing multi-system tumors. Or, crazy enough, you can have activating mutations in G-protein-coupled receptors that literally induce a receptor to signal even when the hormone itself isn't even there.
But what if you have plenty of hormones circulating in the blood, but the receiver itself is broken? Well, that is hormone resistance, and it presents in two main ways. Inherited resistance is pretty rare. It's genetic, involving defects in the receptors. A classic example is complete androgen resistance, where XY males actually present with a female phenotype due to mutated androgen receptors despite having high testosterone. On the other hand, acquired hormone resistance is incredibly common, functional, and often reversible. Think about insulin resistance in type 2 diabetes or leptin resistance in obesity. The body simply becomes desensitized and stops responding to the signal.
Moving to Section 5, Deciphering the Symptoms. As a medical detective, how do you actually spot these chemical imbalances just by looking at a patient's clinical presentation?
The tricky part, and this is a huge takeaway, is that presentations of endocrine disease are notoriously diffuse and nonspecific. Doctors have to cross-reference everyday symptoms to nail down the correct syndrome, like lethargy and depression. That could be hypothyroidism, but it could also be Cushing's syndrome. Unexplained weight loss might point to thyrotoxicosis or adrenal insufficiency. Excessive urination and thirst, polyuria and polydipsia, strongly point toward diabetes mellitus or diabetes insipidus. It's basically a giant puzzle where generalized symptoms have to be carefully pieced together.
Which brings us to Section 6, Playing Medical Detective. How do clinicians actually put this all together and solve the puzzle?
When you're actually diagnosing, you have to follow a really strict sequence. You can't just skip ahead. It always starts with a thorough clinical evaluation. Deep history taking, asking about surgeries, growth, menstrual history, family history of tumors, and just observing the patient's demeanor and appearance. Only after you get those clues do you move to Step 2, biochemical testing. That means checking basal hormone levels and running dynamic tests. And only then do you move to Step 3, radiologic imaging.
And I literally cannot emphasize this next point enough. It is basically the golden rule of endocrinology. Radiologic imaging is used only after biochemical confirmation of a hormonal abnormality. A clinician should never, ever go hunting for a tumor on an MRI or CT scan until the blood or urine work definitively proves that a hormonal dysfunction actually exists. If you search for structural abnormalities without biochemical proof, you are setting yourself up for misdiagnosis by finding clinically insignificant anomalies.
So how do you get that rock-solid biochemical proof? You use dynamic testing. Random basal hormone levels don't always tell the whole story, so clinicians have to actively interrogate the system's feedback loops. If they suspect a gland is hyperactive, they use a suppression test, like the dexamethasone suppression test for Cushing's, to see if they can force the gland to power down. Conversely, if they think a gland is failing, they use a stimulation test, like the ACTH stimulation test for adrenal insufficiency, to see if they can kick it into gear. It's like checking the brakes and the gas pedal to see what's actually broken.
To wrap up this explainer, I want to leave you with something to really chew on. We know from our source material that the immune and endocrine systems heavily influence each other. Immune dysregulation obviously causes things like type 1 diabetes, but crucially, the data shows that modern immune therapies can actually trigger autoimmune endocrine conditions. So here's the question. As we keep developing these highly advanced immunological treatments, are we inadvertently reprogramming our own delicate endocrine network to attack itself? It's an absolutely fascinating frontier in medicine, and it just proves how deeply interconnected our body systems truly are. Thanks for joining me on this one.